So, hello everybody. We're about to have a beautiful clinical perspectives on ketamine panel discussion. We're waiting for Elias to chime in, but we're going to go now. My name is Tijmen Bostoen. I'm a psychiatrist working at Center 45, a specialized center for treatment of psychotrauma. And I'm very, very interested in ketamine, and we're developing an off-label esketamine protocol for treatment of PTSD. So I'm very happy to present to you these clinicians who are very, very experienced in working with ketamine, and I would like to give Veronica the opportunity to introduce yourself and say something about the work you do with ketamine. And after that, we'll go to Raquel and Robert. And after the introductions, we'll dive deeper into this subject. And I hope that Elias has a chance to come in as well. So Veronica, would you like to introduce yourself, please?
Yeah, hello everybody. I'm delighted to be here and excited to have this panel talking on ketamine and this wonderful conference. So my name is Veronica Gold. I am a psychologist from the Czech Republic, and I work as a psychotherapist in the United States. I live in San Francisco, California. And I've been a therapist working with treatment of trauma for about 18 years. And then in the last 5 years, I started to work on the MDMA clinical trials for treatment of PTSD. And about 3.5 years ago, started to work with ketamine. And I'm a co-founder and a therapist at Polaris Insight Center in San Francisco, where we provide ketamine-assisted psychotherapy. And as well, we have developed a training program for ketamine therapists. So that's me, and I'll pass it on to Raquel.
Okay, we're just doing introductions now.
Yes, please.
Yeah, okay, wonderful. I'm Dr. Raquel Bennett. I am a psychologist and a ketamine specialist from Berkeley, California. I started studying the therapeutic properties of ketamine in 2002. So I've actually devoted my whole life and my whole career to trying to understand the relationship between psychedelic experience and mood modulation. So for the past 18 years, that's what I've been doing. I'm also the proud founder of KRIA Institute, which is devoted to understanding the uses of ketamine in psychology and psychiatry. And I'm also the founder of KRIA Conference, which is an international and annual event that's devoted to the same thing. I'm currently on sabbatical to write a book about my what I've learned and about my research.
Yeah, thank you very much, Raquel. And I just saw Elias pop in briefly, but I think he left again. So I think there's a problem with the internet. So Robert, would you please introduce yourself?
Yes, hello everybody. It's the end of the day here. I think it's good morning to you. I'm a psychiatrist from Groningen, which is in the north of the Netherlands. And I became interested in ketamine because I've treated a lot of patients with depression, and specifically so-called treatment-resistant depression, so the more severe, harder to treat patient population that you see in an academic center, and looking for possible improvements of their treatment. We started first on a pilot study. We now have an RCT running, and there's another upcoming RCT, and next to the studies that we do that are blinded, and one of them is still running, we also have an off-label compassionate use variety for people who have had everything that psychiatry has to offer virtually, so including electroconvulsive therapy. And these are patients that have been ill for like 5 years on average in the current episode. Well, we'll go into that more, but that is how I got interested in the field, and gradually also get more of an idea of the psychotherapeutic potential.
Yeah, thank you very much, Robert, for this introduction. And I hope Elias, are you there? So the image froze, I think. So, well, the moment.
Can you hear me?
Okay, Elias, I can't hear you right now. I think your internet is too slow. Elias, can you hear me?
I'm in the country.
Oh, okay.
I can hear you.
Well, I can hear you clearly now. So we're busy with the introductions now. So could you briefly introduce yourself?
Sure. I'm a psychiatrist and a researcher. I'm based at Columbia University in New York City. I've been interested in studying ketamine in combination with various psychotherapies for substance use disorders, looking at ketamine in combination with mindfulness training, with motivational enhancement therapy, and with more eclectic psychodynamic frameworks, in order to figure out how we might mobilize those different resources to help people with addiction as effectively as possible.
Yeah, thank you very much. And you wrote several papers on this subject. So interesting to have you here. Oops, I think we lost Elias again. Oh, he'll be back. Okay, so Raquel, you almost have 2 decades of experience with ketamine. Can you tell us something about the way you work with ketamine in your clinical practice?
Sure, I'm happy to do that. I'm just making a note of the time. Yes, it's true. I became fascinated with ketamine as soon as I had my first encounter with it back in 2002. I was interested in using it because I was struggling with my own severe and refractory depression. And at the time, when I first encountered it, I thought to myself, you know, this seems to have some pretty rapid acting antidepressant properties. I think somebody should study that. And the people around me said, no, that's not possible. There is no such thing as a rapid acting mood enhancer. And I thought, yeah, that doesn't sound right. So bim, bam, boom, here we are. So anyway, my passion, my obsession with this topic comes out of my own experience. But in any case, there's a lot of confusion about ketamine. And some, I think, mistrust of it, which is really a shame. This is a very beautiful and powerful tool when it's used correctly. And adding to the confusion, I think, is the fact that different clinicians have different ideas or conflicting ideas about how to use this tool effectively. What is the optimal way to work with it? So I think what I'd like to do now is to very briefly summarize a couple of different approaches to ketamine treatment that patients might encounter if they're seeking ketamine services. So one way that clinicians sometimes offer ketamine is in a research protocol. They offer ketamine in a low dose infusion. So usually at 0.5 milligrams per kilogram of ketamine as compared with body weight. Patients sometimes get this low dose ketamine infusion. Or occasionally they get S-ketamine nasal spray. It's a very similar philosophy. And the problem is that the ketamine isn't powerful enough to do the magic thing that ketamine does for mood enhancement in such a small dose. And so to get around this problem, the clinicians offer the ketamine, they offer a cumulative stacked series. So they offer 6 ketamine sessions of low dose sessions clustered together in 2 or 3 weeks. The purpose of that is to get enough ketamine into the patient's body to do the magic thing that ketamine does. But the fact that ketamine is psychedelic is considered an annoying and problematic side effect that's to be avoided. And so these low dose exposures, these low dose administrations are designed to avoid having psychedelic or strange or altered feelings as much as possible, and to prevent the patient from having full psychedelic or dissociative experience, because that's considered undesirable. By the way, in this model, there's no psychotherapy. The provider is simply using the ketamine as a pharmaceutical, as a biochemical agent, with an interest in what ketamine does on a chemical level. So there's no doubt that ketamine does something helpful for depression and for ruminative suicidal ideation. It certainly does something on a chemical level that we can observe, but I don't think that's all there is. So there's other ways of working with this tool that I think may be even more effective. Anyway, that's considered the biochemical or the research model. Okay, a different way.
Raquel, you have to unmute yourself.
Yeah, I'm back. Can you hear me
Yes.
again? Okay.
Yeah, we're hearing you. Thanks.
Did you miss any of that?
Yeah,
No?
Yeah, we got it.
You got it. Okay, fantastic. So a different way of working with ketamine. It's the same medicine, but it's fundamentally a different strategy and a different set of values. A different way of working with ketamine is to think of the ketamine as a lubricant or a catalyst or a facilitator for the psychotherapy process. And so when you work with ketamine in this way, you're working, the emphasis is really on the therapy, not on the ketamine. The ketamine is just a helper in the psychotherapy process. So when you work this way, you're still going to work in a sub-psychedelic dose, in the lower dose range, because you don't want the patient to get too far out or too disconnected or too, spacey. So you're still going to work in the lower dose range, but there's going to be an invitation for the clinician and the patient to talk and to really use that special space, that space of relaxation, to revisit material that the patient has been working on and to work it through again, and to really take in the lessons or the learning that they need to take in. I have a lot more to say about this, but I'm going to hold myself back in the interest of time. So that's just the second way of working with ketamine. Okay, now we come to a third way of working with ketamine, a different paradigm. Again, it's the same medicine, it's just a different set of values, a different approach. So the third way of working with ketamine that we need to know about is using it to invite and induce psychedelic experience on purpose. And so you would do that as a provider because you believe that the patient is well equipped for that, so the patient is ready, and also because you as a provider, that you value the visions, the psychedelic and dissociative visions that you can induce by using ketamine. In other words, you're dosing patients straight into the K-hole on purpose. You're not trying to avoid it, you're actually trying to utilize it. And the idea there is that, that those visions are sacred and meaningful, and that in the therapy that follows the treatment, that you can help the patient to find the meaning or find the message and extract it and make use of it in their daily lives. So just in brief, I've just laid out 3 different paradigms for ketamine treatment. One where what's happening at a biochemical level is emphasized. One where what's happening at a psychological or relational level, that's what's being emphasized. And then finally, we're comparing that to if you're using ketamine as a full-blown psychedelic, and where psychedelic and mystical and shamanic experience is emphasized. Again, it's dose dependent and also depends on the intentions and the setting and the patient selection. Those are all the things that go into figuring out which paradigm you're in. Anyway, looking at the time here. So, people very frequently ask which type of ketamine treatment that they should pursue, or as a provider, which type of ketamine should you provide? And the answer is actually that all of these paradigms are valuable. There isn't one that's superior to another, but rather, from my perspective, the skillful and the ethical ketamine provider is knowledgeable about different routes of administration, in other words, different ways of getting ketamine in your body, and is familiar with different dosing strategies. And the ethical ketamine provider, the skillful one, matches the treatment to the patient and is able to provide different kinds of ketamine treatment based on each individual patient's needs. So really that's what I'm about. I'm trying to teach the spectrum of ketamine service. There isn't one right way. There really is a variety of ways to use this very beautiful and flexible tool.
Yeah, thank you very much, Raquel, for this very interesting oversight of the different paradigms we can work with when using ketamine. So it's a very versatile psychedelic, I have the impression. My last question for you is, what paradigm do you use most often in your own practice?
We use all of them. We truly use all of them. We mostly do injectable ketamine. We prefer injectable ketamine. We do it in different dose ranges. You would be surprised to know that only about 1 in 6 patients who approach us are actually a good candidate for full-blown psychedelic experience right from the beginning. And that means that the other 5/6 either are a better candidate for low-dose ketamine or ketamine-facilitated therapy, or no ketamine at all. So if you see a provider who's giving all psychedelic ketamine, you should be wary of that. And I don't think that's the natural distribution. By the way, the next thing I wanted to talk about, but I don't have time, is the different clinical indications for ketamine, the different kinds of, the times when you might use this tool. So if there's time later, feel free to circle back to me on that.
Yeah, that would be interesting. Hope we have time for that later. So, Robert, can I ask you to tell us something about your work, your research you're doing?
Okay, thank you. Well, if you look at the paradigms, then I think we would use number 1 and 2. I think a human being is never unidimensional. So I have a bit of a problem with these very strict boundaries between the different ways you use it, because I think there's always a biological effect. Otherwise, we wouldn't use them. And this has an effect on mood, but it's also, and I've seen it personally, and we know it from studies, it also can help deepen a psychotherapeutic process that a person may be in. For depression, as a clinician, I think treating depression purely with a pill is under-treating the patient, because there's always a story, there's always a personal side. There might be trauma there. Well, there can be all kinds of circumstances that play a role in people's lives. And if you do not address them, I think that is not good care. However, the biological aspect allow us to deliver this kind of care in some people for whom treatment can be very, well, it can be very hard to reach any degree of success because they are so deeply depressed, or because it could be because they have such a huge genetic load, or because they are so traumatized, or whatever the reason is, or because depression is sort of a self continuing and become a process of itself, which you see in patients. So, and maybe that addresses also Raquel's observation that people may need different varieties of these kind of treatments. Regarding dissociation, the people that we only use oral as ketamine because we started with this. We thought it was quite practical. We had some patients that we tried. If oral wasn't successful on IV, and we never had any additional benefit. So and also, if you look at the literature, it's very hard to say that the one is better than the other. There's no good comparative studies, and just eyeballing the literature and from our own experience, we believe that we can help many people with oral. Of course, the dosage needs to be higher, and maybe you need blood levels to check the biological availability. But most of our patients have some kind of dream-like phase, and it may be more or less dissociative. And there's, of course, a whole debate in the literature on whether you need dissociation for a clinical effect. And there was a recent systematic review in the literature that concluded that this question is still undecided. So it could be that without strong dissociation, you will still have these effects. And yesterday and before yesterday, there were lectures on this psycholytic psychotherapy, which is a term from European background, which I think is Raquel's second paradigm. And you can, I think you can sort of tailor per patient the amount that you would need, but I'm not sure that you would need strong dissociation for clinically meaningful effects. Well, that's it for now, I think.
Yeah, that's what Torsten Passi called dynamiting away the ego.
Yes, I like that expression.
Yeah, it sticks. I was wondering, you're working at a university medical center and you're seeing a lot of treatment-resistant patients. How do you think ketamine, what will be its place? I know it's a subject of your research now, but do you think it can be equally effective as ECT or maybe more effective, or is it just too early to say?
Well, I think there's a number of very important questions in this field. We are currently starting a trial in which we will compare oral ketamine, the way that we developed it, with ECT treatment. So we are going to randomize people who have an ECT indication. That means that you've had at least 4 steps, different treatment steps. So 1 form of psychotherapy, 3 different forms of antidepressants without success. We have seen in those kind of patients, even after ECT, that quite a number of them have clinically relevant, and for the patient, relevant improvement. So, but that is the hardest test, let's say, because you're in the final phase of the treatment protocols. We all know that there is now pharmaceutical companies that aim for a place in the protocol that is earlier. I'm not convinced of that at this point. I would say that in depression treatment, so this is not people who want to explore. This is people with a clinical diagnosis who cannot function because of a mental disorder. We have a number of established therapies, and I think we should be cautious in implementing ketamine somewhere in that row without restraint, because there's a number of things we don't know. We don't know the long-term consequences. We don't know how many people get problems with the urinary tract, or cognitive problems, or sexual problems. And probably this is not very dramatic, but there's very few good studies on these issues. And I'm a bit concerned that with the momentum that is created to get this implemented, even though I also see the suffering of people for whom it might be helpful. So I think this is a big dilemma.
Yeah, but it's hopeful on the other side that electroconvulsion therapy, ECT, is the most effective antidepressive treatment we have up until now. And for people who don't recover or improve on that, they still have a chance with ketamine. That's well, at least that's hopeful. I would suggest.
Yeah, and if even if it were equally effective and better tolerated, and you don't need the clinical admission and the ECT sessions and the anesthesia, etc., etc., it would be wonderful.
Yeah.
But you should compare also the cognitive side effects between the two treatments to really know where it could land.
Okay, thank you very much. This was very, very good. Veronica, could you tell us something about your work, please?
Yeah, thank you. Yeah, it's fascinating listening to Raquel and Robert, and I want to share a little bit about how we work. But first, kind of these questions that are coming up for me as we are talking about this, that we are thinking about the different protocols and how easy or difficult it is to create a protocol when working with psychedelics, where, some of the guiding principles that we use is following the inner healing intelligence, the innate capacity to heal. That is something that we cannot really standardize or make a protocol that is kind of joining and following the patient, whatever's coming up for them, as well as healing through the experience. And so that it brings a good question, how protocols can look like. And then when we do research, how do we measure that people are doing better? Is it that we're looking at symptom reduction and we're looking at scales, or bringing really the quality of life? And so we see sometimes symptom reduction, but it doesn't really mean that people are doing better. So that's something, and as well, close to the sessions and sometimes the treatment, what we see is really 3 months or 4 months that we, tell patients, let's, yes, look at these points in the time of the treatment. But it is kind of a unfolding and integrating of these experiences to see how things are shifting. And the last question that's coming up for me is really thinking about the value of non-ordinary states of consciousness and how healing through these expanded states will have an effect of how we look at our psyche, how we look at where the problems are coming from. And if we are reducing that, believing that everything, all the manifestations of the mental health challenges are from what happened in our life from birth to now, or maybe perinatal state, that maybe there is only a limit how we understand the psyche and how we can understand the healing. And that non-ordinary states of consciousness, and this shamanic and transpersonal perspective can really show us kind of greater, this archetypal mystical paradigms that as well can bring some origin of the challenges that people are seeing. So those are just some questions that were coming up as I was listening to my colleagues here. And how we work with ketamine is really in the relational context, so that the relationship with the therapist and patient is the holding container. And we work in a triad with a physician, therapist, and the patient. Occasionally the physician is the therapist, but a lot of times we have this triad that holds the patient in a safe setting in a clinic, very much based on the MAPS clinical trials, on the work of Stan Grof. Our work has well been impacted greatly by Raquel Bennett, as well Phil Wolfson and Julian Andries. And looking at the experience, even in this, in the psycholytic dose and the high dose, that as a potentially really this extraordinary experience in one's life. That a lot of times our patients say that, even one-time experience has been the most life-changing experience for them. It's one of the 5 most, interesting or important experiences in their life. And so us really holding that as a sacred experience every time they come in, and really remembering that, honoring that, and creating space for this unfolding. So it's, really important in the value of the way how we work with the medicine. And we work in the psycholytic doses where the medicine is a catalyst for the unfolding, for the processing of the underlying issues, of course, there is the neurobiochemical benefit of the medicine, as Raquel and Robert are talking about, and then we work with the higher doses where we see it's a good question about the value of dissociation and how, what we've, really observed, that there can be the kind of like the lower level of dissociation, which helps the person to dissociate from like identification with the depression, or identification with the anxiety, or identification with the trauma, or with the perpetrator, right? And having this more distance view that allows them to relate to that differently in their life. But then in the greater levels of dissociation, in the higher doses of working with ketamine, where people have the out-of-body experiences, near to death-like experiences, or the ego dissolution experiences. And not everybody who we work with, we will work with these high doses. It's, and as well, we don't start with those doses. In the same time, people are differently sensitive. So you might think you're starting with someone on a low dose and they will go to a full ego dissolution state. So it's important for us to understand that and be able to support people when they go there. And that's what it's kind of this mystical experience that for some people really can be where the healing happens. Through that experience, they come back and some of their long-term issues have shifted. And that's where, I'm thinking about really revisioning how we think about healing. How does that happen, and how, the model of the psyche as we're looking at it. And, we work with people usually with minimum 3 sessions, typically 6 to 10 sessions. The typical treatment is about 3 to 4 months, but some people we work with more long-term. Some people come for, I think 3 sessions is the minimum. We work with sublingual lozenges and intramuscular sessions. I as well would refer people, if they're interested, to hearing more. We've recorded a short presentation in one of the posters so they can hear a little bit more about how we work at Polaris. But really thinking about the importance of working with this medicine in the context of the therapeutic relationship, and that holding that, has a really good preparation and then integration that starts in the session and continues in the sessions following the ketamine treatment itself. So there is much more I could talk about, but I'm aware of the time. I know there are other panelists, so thank you. And
yeah, it's very, very, very interesting what you said, Veronica. And I have one question. What indications, you mentioned depression, but what other indications do you see in your practice for this treatment?
Yeah, so it is an off-label use. So, treatment-resistant depression is, of course, what, most of our patients are depression, but as well, we work with anxiety, different anxiety disorders, and as well with PTSD. And it is more complicated to working with PTSD, and but we do, me and my colleague Harvey Schwartz, we specialize in treatment of trauma and have, been working with different ways with PTSD with ketamine, but it would definitely require a separate talk, because there different dosing and different strategies of working with different types of trauma. So we would work differently. Someone who's coming with developmental trauma, maybe working really slowly with lower doses and more of the psycholytic therapy for longer term, differently with someone who has one-time trauma. And then people who have more severe trauma and, more dissociation and dissociative disorders, there would be, it might not be the best treatment in the beginning of their, treatment of the DID diagnosis. So it might be appropriate in a later stages of the treatment, but not in the beginning. So it needs more considerations. But those are some of the social anxiety, OCD. So
the versatility is enormous. You can do a lot with ketamine. So let's talk to Elias about addiction and ketamine. Elias, can you?
Yes, can you hear me?
Yes, please.
Hi. Well, it was a pleasure hearing my co-panelists speak. And just to continue positioning ourselves somewhere in Raquel's very helpful heuristic I'm interested in looking at how psychedelic experiences, mystical type experiences, might facilitate the therapeutic process. And so a kind of hybrid of models 2 and 3. And I came to this with an interest in meditation, principally, how meditation training might be helpful for addiction. And after doing some preliminary research with mindfulness training regimens for people with cocaine, cannabis dependence, it was very clear to me that while the idea is quite attractive, it can be very difficult to implement, especially in vulnerable populations where the capacities that might be helpful for meditation training are lacking. And one can see in addiction a clear representation of what those limitations might be, the reactivity, the difficulty with maintaining attention, the challenges with acceptance, with self-acceptance, with accepting uncomfortable states, the failure really to rest where one is and fleeing to whatever might promise some relief for the moment. So the challenge that I faced was how we might facilitate that process. And looking, decades ago to some of the work that was done with classical hallucinogens, it seemed a very feasible idea to consider doing that kind of research, something like the psychedelic assisted treatments that had been developed decades ago. But ketamine seemed particularly attractive to me for a few reasons. It's time limited. It's something that can be given in legal settings. It has a very established medical record. We know quite a bit about it. We know its safety profile. In many ways, it has certain advantages over the classical hallucinogens, and especially in research settings, if one is doing government-funded research. So I started a research plan systematically looking at different doses of ketamine, creating a range of psychoactive effects in combination with various psychotherapies, all of which incorporated some measure of mindfulness training. So what we found thus far is that ketamine can be, first of all, helpful at disrupting some of the vulnerabilities associated with addiction, tenuous motivation, reactivity, heightened craving. It can normalize decision-making around drugs. It disrupts cocaine self-administration in the human laboratory. We found in those initial studies that the psychoactive effects, namely the mystical type effects, were crucial in ketamine's efficacy. They mediated its efficacy on motivation to quit and on cocaine self-administration disruption. We moved on and did various clinical trials with a psychoactive control using various psychotherapies as a platform. So a cocaine dependence trial incorporated ketamine infusions into mindfulness-based relapse prevention, found that ketamine as compared to the control led to a significant proportion of participants achieving abstinence. We did a trial with alcohol use disorders and motivational enhancement therapy, and again, with some measure of mindfulness training around the infusion itself. We found that it reduced the likelihood of heavy drinking days after the infusion. It delayed the time to relapse. And we found in that trial that these results are now awaiting final review by the journal. We found that the mystical type experience mediated the effect of ketamine on promoting abstinence. And interestingly, we also tried to understand whether certain domains of the mystical type experience might be particularly helpful. We found that ineffability the inability to put something into words, the challenge with fitting whatever happened into kind of an existing narrative scheme was was the most important domain. So as I said, those results should be published within the year. Currently, we have several trials going on, building on the results I just shared. A cocaine trial that incorporates 2 quite high dose infusions of ketamine, with the first, as far as I know, outpatient infusion of 1.3 milligrams per kilogram over 90 minutes. We have a trial with alcohol users. It's a 2x2 design to investigate the synergy between the psychotherapy and the infusion, incorporating 2 ketamine infusions on an outpatient basis into mindfulness-based relapse prevention and MET, motivational enhancement therapy. And we have an opioid dependence trial that's investigating whether ketamine can facilitate the transition to extended release naltrexone. So that's you know, I know that we're limited in time, so I just wanted to give an overview of the research we've done. Now, I think ketamine is a very promising medicine. I think with the right level of responsibility, clinician training, and some paradigm shifting, recognizing that this fantasy of medications alone doing the trick should be dispelled, and we should think more widely about how we might more comprehensively treat patients. So I hope that was helpful.
Elias, yeah, it's very helpful and impressive the work you are doing, and I'm looking forward to the publications. And I was wondering, you said the mystical experience is quite important. It probably mediates the effect. So right. How do you think mindfulness fits in there? Do you use mindfulness to prime for mystical experiences, or more to integrate them, or doesn't?
Yeah, so that's a very good question. So mindfulness, you know, as a capacity, has certain philosophical tenets, let's say, associated with it. One is that experiences are transient, and that whatever's happening is fundamentally neutral. And so, you know, it's kind of interesting to reconcile that with this, you know, very robust literature of the psychedelic experience being the top whatever breakthrough in one's life. But, you know, I have certain questions about the utility of that kind of thing. And so the way I've been approaching the psychoactive effects is to give a person the opportunity prior to the infusion to get some access to what it means to be mindful, taking them through mindfulness training, having them experience what it's like for thoughts to come and go. And invariably, also suggesting that whatever is happening is non-binding, that we can experience it and pass through it. So the infusion is approached with that spirit. There isn't any priming insofar as I'm, you know, encouraging them to find communion with the cosmos, or, you know, engage with a transcendent deity. It's follow your breath, pay attention to what's happening, remain accepting. I think the sort of practice that a lot of ketamine providers who have had the right training do, you know, getting all shamanic during the infusion, or ringing bells, or getting rattles out, that, you know, that's unlikely to help. And similarly, we want to help a person recognize the infusion is a stepping stone. It's not the be all end all. It's not what we're aiming for. It's a passage into greater health, into better self-examination, into all of the capacities that we're hoping to cultivate in our patients. So this idea of kind of holding on to the experience as, one of the best in one's life, I have both philosophical and aesthetic scruples against that. There's every moment is rich and robust, and health is recognizing that and maintaining an openness to the abundance before us, instead of hearkening back to some guided psilocybin experience.
Thank you very much for elaborating on that, Elias. So we got an extra 20 minutes for this panel discussion. I'm very grateful for allowing that. Maybe we can go to some questions from the audience. And one question is, are there long-term cognitive deficits observed after repeated ketamine therapy? So, who wants to? Yes, Raquel.
I'll take a crack at that. So interestingly, for patients who were diagnosed with severe and refractory depression, who got a short series of ketamine treatment, their cognitive functioning actually improved. It got better after having a short series of ketamine treatment. And the hypothesis about that is that when people are depressed, they think less clearly, or it's harder to think, and that if you do something that improves the depression, then their cognitive performance on tests actually improves. So that's one finding that I think is important. However, if you look at a different population, if you look at people who are in residential treatment for polysubstance abuse or problematic substance use disorder, and their substance use includes ketamine, those populations tend to go down in their cognitive functioning. It looks like they've had too much ketamine too frequently or mixed with other drugs, and that has a negative effect on cognitive function.
Thank you very much, Raquel. Very clear. I'm very glad there's an anesthesiologist also attending this conference and asking the question if you provide an analgesic dosing during a single instance of interaction, sometimes light sedation for procedures. Is there any interventions I could implement to prime or guide the patients to receive benefits from the ketamine that I'm already administering? So who of the experts would like to jump in? Veronica.
Yeah, I can just share, I think it's a great question, and I appreciate Anat asking this, and that, shows to kind of his care for the patients. And so I don't have experience with that, but we have a colleague who is an anesthesiologist who worked in the VA. And so she talked about, kind of sharing with people that there is this potential of healing that happens with this medicine, even though they're coming for a procedure. And a lot of times people are afraid as they're coming for anesthesia and for the procedure. And so the possibility of having, just pleasurable experience. And, she talked about using, like, she had something that she had, the patients, she had like little stones that they held and kind of could, like go into the experience. So, I don't have a specific tip, but just kind of wanted to appreciate this question and even kind of bringing that sort of possibility of sharing about it with the patients he's working with.
I think there's actually an article published by an anesthesiologist who says when you really prepare someone for the ketamine infusion, you get very little of those emergency reactions that can be quite frightening for people. So
that's in fact true. That has been studied. Can I add to what Veronica said?
Yes, of course. Please.
A couple of things to know. The first thing to know is that ketamine in psychiatry is a separate field from ketamine in anesthesiology. So the goals of the treatment the patient population that you work with, the other adjunctive treatments that are needed, the patient selection process, and the patient preparation process are completely different for working with a patient for psychiatry or psychotherapy. So we need to be careful to not overlap these two things too much. It's a kind of apples and oranges in a way at this point. That said, if you are working from a medical paradigm or you're a anesthesiologist or another kind of a physician and you're interested in working with ketamine in psychiatry or psychotherapy, the thing to do really is to get some training. And there's a lot of wonderful trainings, including one that's being offered by my friend and colleague Veronica, and then a couple of other ones in the community. So I'll go ahead and put some resources for finding more training in the chat. I highly encourage people to get more training if you'd like to work with this tool in your practice.
Yes, thank you for adding that, Raquel. Well, Michiel van der Oever, is there a final common pathway between depression, PTSD, ruminating thoughts, and substance abuse that ketamine works on? Interesting question. Any of the experts want? Elias, please.
Yeah, I think that's a really fascinating question, one I've been concerned with from the start of the research I've done. And my sense of it is, depending on what paradigm we're approaching it from, we could find a compelling explanation. If we're approaching it from the experiential perspective, that somehow whatever ketamine is doing psychologically, experientially, has an impact. It's an interruption. It creates a clearance that can provide opportunity for finding some respite from one's habitual identifications, preoccupations, cravings, aversions, whatever they might be. But that's not the only explanation. There's a lot of emerging literature regarding the default mode networks, role in all of these conditions. And ketamine has been shown to attenuate default mode network connectivity, which may account for its impact on ruminations, but may more generally account for the effects on dampened mental activity in general, be it craving or other fixed notions. But the other explanation, which I think is worth considering, is the kind of mystical experience, providing a realignment of one's kind of interests, perspectives, values with something that is beyond what we ordinarily kind of orient ourselves around. And that's a mechanism that is difficult to speak about sensically without sounding theological, but it's worth considering that there may be some perennial philosophy or primordial way of engaging with the world that ketamine allows, and other mind-altering activities and substances provide opportunity for attunement to.
Yeah, thank you, Elias.
Can I say something in addition to that?
Yes, please, Robert.
Because I think that these are all very interesting topics, and we sometimes see that a too profound mystical, no, let's say a very profound mystical experience may be hard to cope with by people who are less inclined to be very insightful, to be verbally talented. They could be more traumatized, although it does seem to work very well in traumatized people, but maybe not everyone. So I would vote for a very personalized approach, and I was listening with great interest to Elias' talk and also his firm statement that the level of dissociation or mystical experiences associated with outcome in substance use treatment. It doesn't seem to be. Well, I know the literature is very patchy and it's hard to compare, but I was just looking it up. There's this systematic review from Miriam Grabsky, which recently appeared. And they show that specifically, if you look at depression, the association is not so clear. I'm intrigued by this idea that there may be a difference between psycholytic and psychedelic therapy. Psychedelic formulated as having a strong 1 or 2 or 3 time experience, and psycholytic therapy is that you help patients in a psychotherapeutic process have more access to part of their unconscious, the things they struggle with, the things well, what's the English word? So they want to keep far from their day-to-day experience. And then it could be that some kind of observing ego, some kind of sense of control and connection could be relevant. So as Timon was saying, the sort of blow the ego temporarily apart versus have a controlled experience within a psychotherapeutic framework, I think that is an interesting way to look at it. And I was wondering what Veronica and Raquel would say to that. And also, Elias, I was referring to your
I should comment on what you'd said about psychoactive effects. So I because we're limited in time, I didn't go into the nuts and bolts of the trials, but I delineated between dissociative effects, near-death experience, and mystical type experiences to ascertain what's doing what. And mystical type experiences were the only mediating psychoactive effects. So that's congruent to some extent with that meta-analysis you cited. But it should be said that no work has been done yet looking at mystical type effects and how they might be relevant to depression treatment. And also, there hasn't been work done yet to dispel this idea. And I say dispel because, we can be prejudicial in either direction. Dispel the idea that somehow mystical type experiences are dynamite that blow people up. They can also be, with the right level of preparation and guidance, very gentle, very nurturing.
I agree to that. That's not my opinion, but it's all a matter of the amount and here you get the whole thing of setting and set and how people are prepared. And
well, I don't know. I think even thinking about amount, a psycholytic abreaction might be a lot more traumatizing than a mystical type, transcendent type experience. So we should just be careful about characterizations with these substances. That what they do varies depending on framework, on preparation, on what the intentions of both clinician and patient might be. So I just think we have to be very nuanced in our understanding and be very careful about the tropes that we allow into our conversations about ketamine.
I couldn't agree more.
Great. We're all in agreement.
Yes, thank you for your clear point. Veronica, would you like to add to that?
Yes, I just had a thought a little bit about, when we talk about these mystical experiences or spiritual experiences, and that how the integration happens and how it can be different for people, that sometimes it is really, it can be really positive in a way of confirming of beliefs they already have, or kind of bringing a new belief, new experience and understanding of the universe. Sometimes it can be really dissonant to, you know, how they grew up, what they believed, and that can be really distressing. And you know, that needs to then be, you know, integrated in the therapy afterwards. And you know, sometimes people come with like extensive spiritual trauma, and so then that can be brought up by the mystical experience in the sessions, and so that we really have to hold that and be aware of, you know, that possibility of happening. And you know, kind of on the other side as well is when people are hoping for that experience and feel like they haven't experienced it, and having this disappointment of like not having the mystical or spiritual experience. So that you know, I think that it's just kind of thinking about it a little bit further, kind of how we integrate those experiences, and how, you know, that it's not just having the experience, but then how we relate to that in the psychotherapy and in integration of that experience will as well have an impact how helpful or not having that experience is, so that it's both the preparation, the experience, and the integration of that.
Yes, thank you for making that clear, Veronica. There's a question that's been upvoted for the experts. The question is, why are there no RCT studies using higher than 0.5 milligram per kilogram ketamine with or without psychotherapy? There are all these clinics doing it already, but no data. Countries with public healthcare would really benefit. So,
so that's very easy to answer. There are clinical trials. I've done 3 of them, so you can look them up.
yes, but maybe we get into that. The basic protocol seems to be 0.5 milligram per kilogram. You see it very often, but I'm glad there's more variation, because the dosing is I think, like you all mentioned, is a very important factor, and all these doses, low, middle, high, have different effects. So I think we should take them all into consideration. Am I right, Elias?
No, the question was, why haven't there been RCTs done with higher than 0.5? You want to explore also what higher doses might do, and
yeah.
I'm sure Raquel can talk about that, given that this fits better into her, you know, the very helpful scheme. You know, there are some dose-dependent psychoactive effects. Raquel, what are your thoughts?
Raquel, you should unmute, please.
There we go. Well, a couple of things. It's a great question. Thank you for asking. So first of all, psychotherapy is a really difficult variable to study because because there's a lot of intuitive things that happen in every psychotherapy session. It's hard to manualize. It also takes a lot of time and requires a lot longitudinal look. So therapy in general is a difficult variable to study. That's part of it. Part of it is, frankly, that there's some political and economic pressure to not demonstrate that ketamine combined with psychotherapy is optimal. Because if in fact we could demonstrate that, then that would have to become the new standard of care, and insurance companies don't want to have to pay for that. So there's a little bit of behind the scenes kerfuffle about this. So not everybody is eager to see the results of that study. That's another part of it. Part of it is that this field is in its infancy, and there's still a lot that we don't know, and a lot more interesting and important research to be done. Finally, I would say that there is some research about combining ketamine with psychotherapy. Right, what jumps to mind immediately is the Dr. Dorr paper that came out, I think last year. I'll see if I can put it in the chat for you. And there are a number of other ones. There was also Wilkinson who found that ketamine infusion was more effective when combined with CBT. That's not to say that CBT is the optimal way to do this, but there was a well-controlled study that came out that demonstrated exactly that. So for all of those reasons combined, those are some of the things that we're grappling with right now.
Yeah, thank you very much, Raquel. Do we have time for another question? I think so.
I want to talk about S-ketamine.
Yeah, good point.
Sorry to jump in. I think we can do one more question, but we have a lunch break, which is already being shortened a little bit. And I realize this is a very extensive topic. We could do a whole day or a whole week or a whole month probably about this. And it's really exciting, but let's do one more question and we really need to stop, I'm afraid.
Okay, thank you, Erwin. Yeah, let's talk about S-ketamine for a moment. It's been approved from the FDA and EMA, the nasal spray. So, Raquel, what are your thoughts on that?
Yeah. Oh, I'm champing at the bit to talk about this. So S-ketamine. Oh dear. S-ketamine is basically a marketing ploy. It was a way for big pharmaceuticals to find a way to get a patent and to make money off of an existing generic drug, namely racemic ketamine, which is dirt cheap and highly effective. And in fact, all the early studies from NIMH and other institutions were done using racemic ketamine. S-ketamine is essentially filtered ketamine, where I don't have time to explain it in detail, but where the little ketamine molecules that are floating in solution are bent either to the right or to the left. They have the same components, but they don't have the same orientation in space. And so what Johnson & Johnson did, they were trying to make a ketamine derivative that they could patent. They were unsuccessful. And so their revised strategy was to take racemic ketamine, this drug that works really well, and to do something to it. In this case, they filtered it and removed all the right-handed little ketamine molecules, and you're left with left-handed ketamine or S-ketamine. And they stuck that in a solution, and then they pushed that through the FDA approval process. All of it designed to make money for Johnson & Johnson. Okay, here's the part you need to know. It's okay if you didn't understand all that, but here's the thing. Racemic generic ketamine, the way that it's been studied and the way that we've been doing it for decades, a single dose for a psychiatric application is going to cost you about $1.59 in the US. $1.59, that's less than $2, less than a cup of coffee. In contrast, the equivalent dose, the equivalent amount of S-ketamine, this patented product, costs $850. So you might think that S-ketamine, this new product, was somehow superior. Maybe it worked better, but the answer, sadly, is that's not the case. In fact, in recent studies, head-to-head, comparing generic ketamine and S-ketamine, what they found was, what they concluded, this is kind of scary, what they concluded is that S-ketamine was non-inferior. It didn't perform worse than the existing cheap available product. So this is totally outrageous, people. And anyway, there's a lot more I could say about the politics and economics behind this, but I'm going to wrap it up by saying that in order to bring the cost down of ketamine treatment, and in order to make this treatment more accessible, what we need to be doing is using generic racemic ketamine as much as possible and asking for that by name, number one. We need to be using injectable ketamine as much as possible. It's cheap, it's easy, it's precise. So we need to be doing that. We need to be offering group work as much as possible whenever it's clinically indicated. We need to train more people how to do this, how to work with this tool in a competent and skillful way. That'll also bring the price down. And then, of course, we need to push for FDA approval for generic ketamine for psychiatric indication, and also medical insurance, broad medical insurance coverage of this treatment. So if we did those 5 things, we could get ketamine treatments much more broadly available to all the people who really need it and would benefit from it.
Thank you, Raquel, for making that
Thank you, Raquel.
completely clear.
Maybe one short addition, because I fully sympathize with everything you said. In Europe, the situation is different in the sense that S-ketamine is the default. S-ketamine is the generic variety that is on the market for anesthesiology. So The studies we do, for example, are with generic esketamine, which is as cheap as racemic is in the US, just to add to what you're saying. So looking at the literature, it's important to know these differences.
Yeah, I have no objection to anybody using esketamine as long as you're not being price gouged. But here in the U.S., frankly, it's medical extortion, and so I have a problem with the economics of it, but not with the clinical issues. Is not something that I have a problem.
And it gets a bit more.
The same debate is actually taking place in European countries. Exactly the same.
Well, there's one more thing though, Dr. Shovers, that I want to just quickly mention, which is that S-ketamine, or the left-bending ketamine enantiomer, is a little bit more speedy and a little bit more uplifting. It has a little bit more lift than the racemic mix or the R-ketamine, the right-handed ones. And so that's probably pretty useful for treating unipolar depression. But when it comes to treating people with bipolar depression or depression with prominent anxiety, the R-ketamine, the right-handed one, the one that's been eliminated, that actually has a more sedating effect. And it turns out that we think that the balance, the mixture in racemic ketamine that combines left-handed and right-handed enantiomers, that actually may be optimal for treating certain kinds of patients. So before we throw the baby out with the bathwater here, before we say that esketamine is somehow better, we need to really take a close look at what each molecule is contributing, and then thinking about the patient populations, and really being smart and thoughtful about which combination or mixture is going to be the most clinically effective. So
I should add that there's already preclinical research suggesting that R-ketamine and S-ketamine promote neurogenesis through very different mechanisms. Hashimoto's group. So there's, from a preclinical perspective, an argument for giving racemate. But it's true that the tolerability of the two may be very different. And despite J&J's protestations to the contrary, we may be having more aversive effects to esketamine than to ketamine.
Yeah, it's an unresolved issue, and we should discuss it and look at it in good studies. And
absolutely,
the background debate on the economic interest, however, is very present, and that also complicates these developments. So I fully agree with that.
So that was the last question to be answered, the esketamine question, I think. Well, thank you very much. It was a pleasure having you here, and all such wisdom, clinical wisdom, all together. I think we can go to the after talk rooms. I'm looking at Erwin. He's nodding his head. So for the people who want to, we can go there and continue this discussion. So.
Yeah, I just added the link in the chat again, so you can follow that link if you want to join the room, because I really feel this discussion can continue for a long time, and I think many important topics were addressed, but there's so much more to talk about. But so thank you very much, all of you. It was really great to have you here. Now we have a half an hour break still, and that might be lunch or breakfast or dinner for you. So I hope there's enough time before the next track will start, and that will be one clinical applications of psilocybin, and the other one will be qualitative research into ayahuasca. So I'm really looking forward to that. And I just wanted to let you know there were around 250 people watching this session all the time, so there was a lot of interest. And I'm happy that we could continue a bit longer, because I think a lot of important topics were addressed. So thank you very much all, and see you all soon again.
Thanks.
You can get out of here.